Good evening, everyone. Welcome to tonight's edition of the National Fellows Online Lecture Series. This series is sponsored by the Fellows Online Education Subcommittee, the Education Committee, and the Fellowship Committee. We've got a great lecture this evening brought to you by Dr. Stephanie Tao as she teaches us about sports medicine considerations in the adaptive and para sports. Now, tonight's lecture is going to be slightly different than our normal lectures. This is actually a pre-recorded lecture because Dr. Tao is giving another lecture on the national stage this evening as well. So unfortunately, we won't have a live Q&A session, but I'd still like to go through some of our goals and objectives. So as you know, the goals of tonight's lecture, as well as this entire online education series, is to serve as an adjunct to individual programs' educational content, to provide fellows with direct access to educational experience with the AMSSM membership, as well as at times some invited guest experts, and also assist in your CAQ exam preparation. We'll bypass the rules for tonight's session, but I do want to point out that we are seeking your advice and input for potential lecture topics as well as potential speakers. So you can go to amsssm.org under the Education tab and the Fellow Online Lecture Series and get to the submission information form. Or if you'd like, you can scan this QR code that will take you directly there. Remember that the primary goal of our lecture series is to assist in CAQ exam preparation. So we want to hear from you what topics we might be missing or would be for covering again to better prepare you. So now it's my pleasure to introduce Dr. Stephanie Tao, who will be our presenter this evening. Dr. Stephanie Tao completed her undergraduate degree in neuroscience at Johns Hopkins University. She earned her medical degree at University of Medicine and Dentistry of New Jersey, which is now Rutgers University, and completed her residency and chief residency in physical medicine and rehabilitation at UT Southwestern. Dr. Tao is one of only 4 physicians in the U.S. currently to have completed dual fellowship training in the subspecialties of pediatric rehabilitation medicine and sports medicine. She performed her pediatric rehabilitation medicine fellowship at the University of Colorado Children's Hospital, Colorado, and her sports medicine fellowship at Children's Mercy Hospital in Kansas City. Dr. Tao is board certified by the American Board of Physical Medicine and Rehabilitation in physical medicine and rehabilitation, sports medicine, pediatric rehabilitation medicine, and brain injury medicine. Dr. Tao has a passion for working with athletes and patients with all types of abilities and is the head team physician for Team USA's Paralympic swimming national team. She also serves as a national medical classifier for U.S. Paralympic swimming. She has a wealth of experience serving as a team physician and medical director for multiple sports medicine teams and events, inclusive of many adaptive and para-sport organization and events. Previously, she has served as director of the Dallas-Fort Worth Adapted Sports Coalition from 2020 to 2022. She also volunteered as a sports medicine physician during the 2020 Tokyo Summer Olympics. Dr. Tao is currently an assistant professor at the University of Colorado in the Department of Physical Medicine and Rehabilitation, specializing in pediatric rehabilitation medicine, pediatric sports medicine, adaptive and paramedicine, and pediatric pain medicine at the Children's Hospital of Colorado. So though no additional introduction is needed, Dr. Tao is highly qualified to give this presentation, and we can't wait to learn from her. So from here, I'll turn it on over to Dr. Tao.
Hi, everyone. My name is Stephanie Tao, and I will be presenting on sports medicine considerations in adaptive and para sports. I have no relevant financial disclosures for this talk tonight, other than my volunteer roles as head team physician for Team USA's Paralympic swimming national team and my role as a national medical classifier for U.S. Paralympic swimming. One other disclosure I would like to have is due to my experience being more heavily involved with the Paralympic movement, we're going to be talking more about topics relevant to the Paralympic movement tonight. However, we will reference some other para sports or adaptive sports organizations or movements as well throughout the talk tonight. My goal for you to learn by the end of this talk, I would love for you to be able to describe the benefits of adaptive and para sports for people with disabilities, describe progress made in adaptive and para sports history and future directions, utilize current terminology when discussing adaptive and parasports, discuss the purpose and basics of how classification works in competitive parasports, and identify common medical injuries or illnesses and sports medicine issues when caring for athletes with disabilities. So let's start by talking about adaptive and parasports history. We're going to start with this video that's presented by the International Paralympic Committee that's outlined the history of the Paralympic movements and where we've gone.
Inspiring and exciting the world with elite sport, the Paralympic Games have grown into the third largest sporting event in the world. Transformed from a disability movement to one with sport at its core, para-athletes create a more inclusive society and inspire the world to believe that anything is possible.
Your performances will inspire and excite the world. You will not just inspire a generation, but many generations to come.
The Paralympic movement started with the vision of one man, Sir Ludwig Guttmann. Beginning in 1948 with an archery competition for injured service personnel in Stoke Mandeville, England, it grew into the Paralympic Games. With increasing commercial support and growing media coverage, athletes now compete in world-class venues in front of sold-out crowds and billions of TV viewers.
Oh, that's an amazing shot!
Every time I go to sleep, I dream that I can still see. And then, I wake up through the dark, and that's tough. It's a crucial aspect of rehab to find something to motivate you and experience relevance, and sport is a great way to make that happen.
I love the feeling in slalom, in downhill, the feeling of speed. When I'm ski, I'm free.
People finally acknowledge that behind Alex Zanardi there are an incredible amount of fantastic athletes who work really, really hard to realize their dreams.
Embracing social media like no other, athletes are giving unique insights into what it's like to be a proud Paralympian. Away from the Paralympics, the movement is bursting with sport. On average, a major international or regional sporting event takes place every 2 weeks, whilst regional, multi-sport events are providing the perfect stepping stone to the Paralympic Games. Athletes are also becoming household names, recognized for their stunning performances. By displaying the Paralympic values of courage, determination, inspiration, and equality, athletes are creating seismic shifts in attitudes towards people with an impairment.
We are equal to other people. We are equal to each and everyone. We have equal values. We can do everything we want. That's equality.
Through the Agitos Foundation, the IPC aims to develop sport opportunities for all. No other movement drives social inclusion through the incredible abilities of athletes. Through sport, athletes challenge the way people think about themselves and how they think about others, leaving tangible legacies.
We will never think of sport the same way, and we will never think of disability the same way.
By enabling athletes to achieve sporting excellence, the Paralympic movement will continue to inspire and excite the world. together. We are spreading a message of respect and equal opportunity for all individuals.
I hope you enjoyed that video by the International Paralympic Committee. So you heard them talk mainly about the history of the Paralympic movement, but even before the Paralympic movement was born out of that Stoke Mandeville Games competition led by Sir Ludwig Gutmann in 1948, it's thought that the first organization that was really recognized for sporting opportunities for people with a disability was the Sports Club for the Deaf in 1888. And then in 1924, there was the International Silent Games event. And then in 1940, you see the National Wheelchair Athletic Association developed, followed by the first National Wheelchair Basketball Tournament in 1948, and that's Stoke Mandeville Games in London in 1948. The Paralympic movement becomes an international movement in the Netherlands, with the Netherlands joining in 1952. And then you see the first Paralympic Games, as referenced in the video, in Rome in 1960. So then multiple different adaptive sports organizations develop over time. You see ones that are more specific to certain conditions, like the U.S. Cerebral Palsy Athletic Association developing in 1970s. But you also see ones that are more generalized, like Disabled Sports USA in 1967. Which, if you actually fast forward to 2020, Disabled Sports USA plus Adaptive Sports USA are two organizations that were separate in the US, and they merged in 2020 to become Move United, which is one of the largest organizations in the US that focuses on adaptive sports. And so if you fast forward, there's a lot of progress made, but particularly pointing out on this slide, looking at the 2016 Paralympic Games, which were the last Paralympic Games prior to the pandemic, you see 160 countries involved compared to the 23 in 1960, and then about 4,350 athletes in the games versus 400 back in 1960. So a lot of progress over time. And even more, progress more recently with the Olympic and Paralympic medals becoming equal in 2018. The USOC, through the U.S. Olympic Committee, becoming the U.S. Olympic and Paralympic Committee in 2019. And I believe we're the first country to have the Olympic and Paralympic title under one committee. We were the first to do that, I believe, from what I've heard. And then in 2022, more recently, Paralympians are now allowed to have that credential PLY after their name, which was introduced for the Olympic equivalent in 2017. So let's start by talking about the benefits of sports or physical activity, why it's important that we talk about this tonight, and our role as healthcare providers. So I think we all understand that as sports medicine providers, right, that there is benefit for sports participation, exercise, physical activity for almost all people out there, right, depending on your medical conditions and your medical history. It can help with reducing chronic disease and overall improve your overall health. It can also decrease comorbidities like obesity or cardiorespiratory illnesses, and it can also improve cardiorespiratory fitness. It can build up muscular endurance, but it also has huge benefits in psychosocial health and development as well. Further along with the importance of impact of physical activity and exercise in sports, we see improvements in improving muscle strength, flexibility, balance, mobility, efficiency, not just walking, aerobic and anaerobic capacity. However, in the US, we have a lot of people, 54 million Americans, who are living with a disability. That's about 19% of our population. As we know, athletes or people with disabilities are more likely to be obese compared to those without disabilities. And that's because, one, there's an access issue with physical activity, with sports, with exercise. But two, there might be a bias in terms of, healthcare providers or other people in society to promote exercise in this population. So it's really important to focus on this so we can reverse the trend. Based on data from the CDC, adults with disabilities are 3 times more likely to have comorbidities like heart disease, stroke, diabetes, or cancer. And nearly half of all adults with disabilities get no aerobic physical activity. However, if you look at the data, adults with disabilities are 82% more likely to be physically active if their doctor recommended it. So why are we not doing this more? We need to be focusing on this. And I encourage all of you to be more inclusive about physical activity and exercise recommendations, and getting to know resources in your community where you end up practicing, so that you can help people with disabilities if they come into your clinic, or if a colleague consults you. This slide just also shows that as you have more impairments, you're also less likely to be physically active. And so it's even more critical to focus and assist people with more serious medical conditions that can lead to multiple impairments. The U.S. Department of Health and Human Services has activity recommendations for adults and pediatric populations. And in general, they say that adults with and without disability should get 150 to 300 minutes a week of moderate intensity aerobic physical activity. Or if you're talking about vigorous intensity of exercise, then 75 to 150 minutes, and that you should incorporate muscle strengthening at least 2 or more days a week. And they note that for someone with a disability, that you would just modify things to try to strive for this if they're able. Similarly, they have guidelines for children and adolescents. For really young children, 3 to 5 years of age, they just basically encourage active play to focus on their developmental milestones and their growth and psychosocial development. Versus once you get into the 6 to 17-year age range, they do recommend 1 hour a day of moderate to vigorous physical activity. And they note here at the bottom that when you're not able to meet these guidelines, to work with a healthcare provider or specialist in physical activity for further guidance. And yes, this is very important, but we need more data in terms of what are the specific guidelines for athletes or people with different types of medical conditions, right? Because as we know, someone with, for example, a spinal cord injury has pathology with their physiology. And so if their physiology is not normal, they're going to have different impacts of how exercise impacts their body, their anatomy, cardiovascular health, their risks for developing other comorbidities, right? And so it's possible that someone with a spinal cord injury may not need to strive for 150 minutes of moderate intensity exercise each week. They might need less. We don't know. And so more research is needed in this area to be able to provide more evidence-based guidelines for people with disabilities. But for now, the most guidelines, including the CDC and the World Health Organization, do recommend just modifying and striving for the same guidelines as people without disabilities, if possible. But again, being thoughtful of their medical conditions, right? Like if someone has Duchenne muscular dystrophy, you're most likely going to have more limitations on the amount of exercise that they do or the types of exercise that they do, because you don't want to worsen their dystrophinopathy. So let's talk a little bit about current terminology and definitions. I do want to highlight this because language has a very big impact on culture. So you may hear the words adaptive or adapted sports. That connotes sports that have been modified from its original form. For example, wheelchair basketball has been adapted from traditional basketball. You may also hear the word disabled or disability sports. That's a popular term used to refer to sports for individuals with disabilities or impairments. And you also may hear parasports. Parasports, it's technically more inclusive than saying adaptive sports because it does not connote that a sport has been adapted from another form. It actually connotes to a sport that is in parallel to a different sport. So the word the prefix para, meaning at one side of, beside, or side by side, similar to how it's used in paralegal. And so an example here is the Paralympic movement is in parallel to the Olympic movement. So this is more inclusive of sports that aren't necessarily adapted from other forms. For example, the sport of goalball, which is for athletes with visual impairment, has not been adapted from a prior Olympic sport. Para-athlete connotes an athlete with an impairment who participates in parasport. And then you also hear Paralympic sports. The important thing to distinguish here is that this is different from para sports, and that para sports is more vague, more general. When you say Paralympic, with a capital P, this is recognized by the International Paralympic Committee. So this is their list of sports that they recognize officially and are sports as part of the Paralympic Games. A Paralympic athlete is an athlete who participates in a Paralympic sport. And then the Paralympic Games is the most elite international level competition for Paralympic athletes. That's in parallel to the Olympic movement. And then a Paralympian is an athlete with an impairment who competes in the Paralympic Games, similar to an Olympian in the Olympic Games. So the other thing I wanted to clarify in our talk tonight, again, like I mentioned, there's many different adaptive sports organizations and movements going on in parallel to the Paralympics. Special Olympics is the other big one that I think many people hear about. And I think oftentimes people confuse the two. And so I wanted to clarify this, but certainly there's a lot of different movements out there too, like Deaf Olympics. There's different blind associations or organizations. The International Blind Federation runs different events. So just a lot of different movements going on there for different types of medical conditions. Paralympics traditionally, they have athletes compete under eligible diagnoses and impairments, and they need to meet certain eligibility criteria for that. They also are primarily focused on athletes with physical and visual impairments, although have a few sports that include intellectual impairments. Whereas Special Olympics is primarily focused on athletes with intellectual impairments. Traditionally, Paralympics has been focused on elite competition and on performance sports. However, over time, this has evolved as we've recognized that you can't just, grow elite athletes overnight. There needs to be a pipeline. And so Paralympics, a lot of Paralympic sports have gotten more involved with developing younger leagues or opportunities for competition at lower levels to provide younger or more novice athletes experiences to become more competitive. Special Olympics traditionally was focused on people with intellectual impairments over the age of 8 years old, however, with any ability level. However, this has also evolved over time and they have younger leagues now. And both are very large international organizations representing many different countries. So let's talk more about how do athletes compete when it comes to para sports. And in particular, we're going to focus on, again, the Paralympic movement. So that's classification. And classification is specific to the Paralympic movement, although it does exist in some sports outside of the Paralympic movement, but all Paralympic sports have a classification system. So basically, what is classification? Well, we do see this outside of the Paralympic movement. For instance, in traditional sports, we see athletes compete based on age or their gender, or sometimes by their weight class, depending on the sport, such as in wrestling or judo. But we don't call it classification, right? We just say, oh, this is the age group that you're competing in. For Paralympic sports, we add an extra layer to that, right? Because every athlete, there's so many different medical conditions and impairments that present that you need to find a way to level the playing field. And so the goal with classification is to take the impairment out of the picture so that athletes can compete based on their skill, their athleticism, their training, and not based on that impairment. And so basically it takes the athlete and puts them in certain categories so that they're competing with others who have similar impact of their impairment on their sport. There are 3 steps to classification. The first is making sure they have an eligible permanent impairment. And actually before this, they need to have an eligible permanent medical condition that leads to that permanent impairment. And so, for instance, fibromyalgia, we recognize is disabling, but is not an eligible impairment or medical condition in the Paralympic movement. So once you are deemed having an eligible medical condition with an impairment, you are presented before a classification panel that does a more thorough evaluation. They obtain a thorough medical history. They determine what of your medical history is eligible to be examined in the classification process for that sport. And then they do a physical exam, which also includes a technical assessment that looks at how you function in the sport based on your impairment. They basically score you or find the best way to fit you into a sport class. And then that's the sport class you're given to compete. So in the Paralympic movement, there are 3 broad categories that are deemed eligible impairments, and that's physical, visual, and intellectual impairments. Within the physical impairment category, there are 8 subcategories that are eligible, as outlined on this slide. So impaired muscle power has to be permanent muscle weakness, such as from a spinal cord injury. Limb deficiency is a congenital or acquired amputation or limb difference. Leg length difference is an eligible impairment. However, it usually needs to be quite significant. For example, in the sport of paraswimming, it needs to be at least a 200 millimeter difference. Short stature, such as from achondroplasia or skeletal dysplasias, hypertonia, that includes spasticity, dystonia, rigidity. These can be from cerebral palsy, from Parkinson's, from a brain injury. And then you also have ataxia, which is quite broad, athletosis, and then impaired passive range of motion, which can be congenital, such as from arthrogryposis or from contractures that are developed from acquired conditions later in life. So this slide gives you an example of what I was talking about previously, that every sport has its own criteria for what is eligible for athletes to participate for competition. And so again, to highlight here, this is for competition. Certainly if an athlete just wants to participate for fun or recreationally, most organizations are very welcoming. But when you start talking about competition, there are some gains and benefits that come with competition. And so there are rules on who qualifies for different sports. And so in this table, you can see in each row, there's different Paralympic sports highlighted. And then the columns all represent different categories of impairment. So you can see that some sports are quite inclusive of all of the impairments, for example, such as swimming and track and field, whereas some sports are minimally inclusive and mainly only focus on a certain impairment, such as goalball or judo, mainly focuses on visual impairment. And then you've also got a bunch of different sports that have more than one, but not all of the impairments. Something you want to look at here in this last column, this highlights into the sports that do permit athletes with intellectual impairment to compete. And there's only 3 sports there. That's swimming, table tennis, and track and field. So like I said before, the Paralympic movement, while it does include some athletes with intellectual impairment in some sports, most athletes with intellectual impairment will be competing in Special Olympics. On this slide, I wanted to highlight that every sport is different with how they do their classification process, and also what the sport classes are in each sport, what is eligible. And that makes sense, right? Because every sport has different biomechanics, different functions. And so just because you have an impairment that is seen in all sports, it does not mean that impairment is going to impact the functions of that sport the same way. So this upper left corner, this is an example from Paralympic swimming. This is the S6 class, which is a middle tier class. And you can see athletes all look very different. So you might see some athletes that look similar in a class, but sometimes they may look different. The thought is that they all have the same or similar impact of their impairment on that sport's functions. In this bottom right corner here, you see the schematic for track and field. So they use a 3-character system. The first character is whether it's a track or field event. The second character is a number that corresponds to their disability their disability category. So what type of impairment do they have? And then the third character indicates the level of impairment. So how significantly does their impairment impact them in that sports function? functions. And typically you'll see that classification numbers, if they're lower, that usually means that an athlete is more severely impaired, versus higher numbers mean that they have less impairment. But again, every sport has its own different classification classes, and how they allocate different athletes. And in swimming, we have a bunch of different classifications. This lower left corner shows you all the different classifications we have. The S class is for freestyle, backstroke, and butterfly. The SB class is for breaststroke. We use a point system to determine what class athletes go into, and those points are determined based on their physical exam. So there's a scoring system. Versus track and field, they use more of a descriptive model. So for instance, they will have a certain description for an athlete who looks like spastic hemiparetic cerebral palsy. So they will go in a certain category for that. So again, every sport has its own different system. Okay, let's talk about sports medicine considerations. So most of the data we know for sports medicine considerations in para athletes is based on the games literature, particularly the Paralympic Games and the Olympic Games, but we're starting to see more data come out from the more minor games events like the Pan Am Games or other games. But we definitely need more data at recreational levels, at youth levels, at lower level competition levels. It's just that the data, it's been difficult to acquire, because you can imagine when you are in a lot of these adaptive or para sports events, usually they don't have healthcare providers or athletic trainers to help gather this data, versus when you go to the games, they usually have healthcare providers. So the data is difficult to acquire at these lower levels. There is, based on the data, from the games, a higher rate of illness in Paralympic athletes compared to Olympic athletes. But if you look at other medical complaints, they are similar to athletes without impairments. It is important to know the baseline physical exam and function for a para athlete, because as you can imagine, their baseline exam usually will not be normal. Because by definition, to participate in the Paralympic movement or in para sports, you should not have normal anatomy or physiology, because you have an eligible medical condition that makes you eligible to participate in that sport. So in that case, you also need to take into consideration what those impairments are before you do a physical exam, and modify your exam techniques to be customized to that athlete's impairments. For example, an athlete who has a visual impairment, when you're doing a concussion evaluation, it may not make sense to do a BOMS exam if they have more severe blindness. But again, don't always make assumptions either. Just because someone has a unilateral amputation does not necessarily mean that they can't balance really well on their lower extremity. In fact, sometimes they may have improved balance compared to someone without an amputation, depending on how long they've been living with their amputation, if they were born with it, what skills they have at baseline. Based on data, we also see that in athletes, in wheelchair athletes, they are more likely to have upper extremity injuries, especially of the shoulder, and they tend to have more overuse injuries compared to acute injuries. Risk factors for injuries usually involve improper equipment or improper equipment fit, which also includes sport chair setup. Unfortunately, due to the scope of our talk tonight, we will not be delving into the proper equipment considerations for adaptive sports, because that could be a whole day-long course. But there may be a course coming out on that in the future, so keep your eyes peeled. Otherwise, improper training and overuse also can contribute to injuries. And it's important to remember that overuse may not just be in the sporting context, but in everyday activities. For example, a wheelchair athlete has a lot of load on their shoulder and does a lot of overhead activities every single day because of the manner in which they have to mobilize every day to get around. And then, couple that with an overhead sport such as swimming. Now you know that the shoulder is going to be the highest risk injured body part because of the chronic overuse in that area. And so it's really important to take those things into consideration when taking care of para athletes. So let's delve into a case example, and then we're going to talk about specific considerations based on the big most common categories of medical conditions you'll see in the Paralympic movement. So here we have a 31-year-old female Paralympic cyclist. She has a history of a T4 complete spinal cord injury and no other medical history. You're covering her first paracycling competition of the year, and she's trying out a new hand cycle, and it happens to be a hot summer day. And shortly after her first event, she comes over and she's complaining of a pounding headache and nasal congestion. She's also letting you know her spasticity is worsened in her lower extremities. And so what is the leading differential diagnosis that you're thinking about? So you absolutely need to be thinking about autonomic dysreflexia in this situation. So what is autonomic dysreflexia? If you're going to see it, it's going to be in an athlete with a spinal cord injury with a lesion at T6 or above. And most commonly, it'll happen athletes with a complete spinal cord injury or at higher risk than in an incomplete. But again, T6 or above, it's very rare to happen below that level. And what happens there is that if you have some type of noxious stimulus, such as more commonly the full urinary bladder that has not been catheterized, or a fracture or some other stimulus, that leads to an afferent stimulus. It goes up your spinal cord and it causes, as it's going up your spinal cord, it causes a large sympathetic response, which causes vasoconstriction, which leads to hypertension. And the hypertension can sometimes, if it's not controlled well or addressed immediately, can skyrocket quite quickly up to the 200s. And patients are at risk for stroking out. So this is why this is an emergency. The baroreceptors detect a hypertensive crisis. That gives feedback to the brain. The brain decreases the heart rate. And then you also see the spinal cord injury blocks the descending inhibitory signals. And so it can't calm down that stimulus or calm down the reflexive sympathetic response. And so you see the cyclical effect where the blood pressure is constantly going up, up, up until you address the noxious stimulus. And so autonomic dysreflexia, the most common symptoms you'll see with it are headache, flushing, congestion, or anxiety, like a sense of impending doom, diaphoresis, blurry vision, piloerection, or nausea. It can happen at subthreshold levels on a regular basis. So it's important to check vital signs immediately if you have an athlete who comes over with any of these symptoms and has a history of a spinal cord injury at T6 or above. What you will see is severe hypertension, and then sometimes bradycardia, sometimes the heart rate's normal, sometimes you'll see tachycardia. So the heart rate's not as reliable, but what you're looking for is severe hypertension in the context of these other symptoms. What do you need to do? You need to, one, sit the athlete upright to reduce their intracranial pressure immediately and loosen any clothing or strapping on them. You're going to want to scan head to toe really quickly while asking the athlete any pertinent questions, such as when did they last catheterize, when they last have their bowel movement, to try to figure out what is causing the noxious stimulus so that you can try to relieve it. But sometimes you can't relieve it, right? Like if someone has a fracture, they're going to still have that noxious stimulus, that pain. And so if you're not able to relieve it or you're not able to find the noxious stimulus, you want to apply a rapid acting hypertensive such as nitro paste. And then you want to check their vital signs frequently, every 3 to 5 minutes while that nitro paste is applied. So you will apply it above the level of their spinal cord injury. So most commonly at their chest, but if their spinal cord injury is higher than that, you can also apply it over their forehead. And then once their systolic blood pressure comes down to 130, that's when you want to remove the nitro paste. But again, monitor their blood pressure frequently if the noxious stimulus has not been relieved, because if they spike back up again, you may need to apply it again. And of course, you're going to get them to the emergency department if they remain hypertensive. So in this case, the athlete, because she had a new hand cycle, she wasn't as familiar with it. The strapping system was too tight, and that's what caused the noxious stimulus. You realized this, you were quite adept on this. And so then you relieve the strapping, and then ta-da, her symptoms and her blood pressure normalized. So that's great. So what else do you need to worry about in spinal cord injury? So basically for these big categories, I talk about medical emergencies and urgencies, and then I also talk about other things to think about so that things don't turn into medical emergency or urgency, and then some considerations when we're dealing with different populations. So if you see sudden changes in spasticity, you should be searching for an underlying etiology. Remember that athletes with spinal cord injury are likely to have a decreased bone mineral density, which increases the risk of fractures, even from smaller bumps that usually don't cause fractures. Because of impaired thermoregulation, they can have increased risk of heat illness or cold illness in contexts that you would not expect it. Always remember to obtain a thorough medical history, including medications that an athlete's on, because medications can increase risks for different side effects. For instance, anticholinergics can increase the risk of heat-related illness. And then watch for pressure ulcers or any issues with skin integrity. If this is not treated appropriately, it could lead to osteomyelitis or sepsis, or if you have pain, if an athlete has pain from it or an infection, it can lead to AD as well. And then if an athlete has a history of a spinal surgery and they have hardware, remember that that's a risk for re-injury as well, particularly of the cervical spine. Other medical issues to consider in spinal cord injury, remember that they oftentimes have impaired motor and sensory function. So this can lead to occult injuries in insensate regions. Impaired cardiovascular function can cause dysautonomia, orthostatic hypotension. Increased pulmonary function impacts their athletic performance. Loss of blood flow regulation by their central nervous system also impacts performance and increases risk of illness or injury. They have bowel or bladder dysfunction, which can lead to infections or constipation. And then wheelchair athletes, remember to look for upper extremity entrapment neuropathies. So when you're preparing to take care of athletes with spinal cord injury, of course, we want to educate all of our athletes and anyone who's working with athletes, but particularly for spinal cord injury, watch out for the practice of boosting, which is intentional autonomic dysreflexia, to take advantage of that sympathetic response. And so educating people about not doing this. This has improved over time based on research, as we've educated athletes that, they should not be intentionally going into autonomic dysreflexia to take advantage of that sympathetic response, because that increases their risk of brain injury or stroke. Prepare for expected environments. So hot environments or cold environments, but remember that it may just be like an indoor event, right? For wheelchair rugby, but if you don't have air conditioning or it's really cold and they have impaired thermoregulation, they may still have heat illness, even though they're not out in the sun. And then have nitro paste or some short-acting hypertensive available in your medical kit. And then also consider an abdominal binder or compression stockings for orthostatic hypotension or dysautonomia. You'll also want to encourage athletes to hydrate well, go to the bathroom frequently, have extra catheters and bowel medications on hand, have appropriate antibiotics, particularly if they've had urinary tract infections in the past. They usually know what medications are more effective for them. But just remember that sometimes as they take more and more antibiotics, they may build up more resistances. And of course, avoid fluoroquinolones because you don't want to have any tendon ruptures or injuries there. Probiotics for neurogenic bowel. And then, of course, for all athletes, practice good hand hygiene prior to catheterization, using sterile catheters, performing frequent skin checks and weight shifting to make sure that they don't have any pressure ulcers. Okay. Spina bifida is similar in presentation to spinal cord injury, but it's important to remember it is different in terms of pathology and physiology. It's a congenital condition, most commonly presenting in the lumbosacral region, but you can have this in the thoracic or cervical levels as well. Important thing to remember here is that most commonly athletes with spina bifida have a latex allergy, and there's cross reactivities to that. So thinking about the different food items that can have cross reactivity to latex. Oftentimes they will have an associated Chiari malformation or hydrocephalus, and some may have a shunt. So making sure you're watching for signs of a shunt malfunction, such as change in cognitive status or focal neurologic findings, headaches, changes in their spasticity. And then also looking for tethered cord syndrome. Again, this is more of a chronic thing, but if they have back pain or shooting pain in their lower extremities, changes in their neurologic clinical presentation, particularly in the lower extremities or their bowel and bladder. Some may have an intellectual impairment, more of like a cocktail party conversation presentation. So keep this in mind when you're talking with these athletes if they are not making the most sense to you. Some may have club feet or other contractures, and then neurogenic bowel and bladder should be considered as well. So make sure when you're preparing to take care of these athletes that you avoid all latex products. You have an EpiPen available because of their risk for allergies. Get them to the emergency department if you're worried about a shunt malfunction, and then urgent referral to neurosurgery if you're worried about a tethered cord syndrome. For athletes with limb deficiency, so it depends on if it's acquired or congenital, right? But both of these have a lot of different etiologies, right? So it's important to understand the etiology of why someone has a congenital or acquired amputation. For some congenital conditions, it may just be amniotic band syndrome and no other conditions, but there are some that are associated with different syndromes, which can give you a clue as to if you should expect underlying heart disease, respiratory issues, kidney issues, or other organ systems involved. For acquired conditions, thinking about if someone has an amputation because they had uncontrolled diabetes, they're going to be at risk for perhaps other cardiovascular issues, that could be comorbidities from their diabetes, or skin issues, right? They can also, if someone has like a vascular issue, like peripheral vascular disease, and that's why they had their amputation, right? That these all give you hints as to things you should look for when you're evaluating an athlete. And so it's important to understand an athlete's underlying medical history. If you see skin issues of the residual limb, that could lead to skin infection or abscess, and then that infection could seed to other areas, including the bone, causing osteomyelitis, or the blood, causing sepsis, or other organ systems causing sepsis. And so, and then when you're traveling with these athletes, you need to also consider fluid shifts, new pathogens, and the change in environment. And so it's important. To make sure you address all of those things, protect their skin, particularly if they have ingrown hairs, if they've had recurrent cellulitis issues, erythema, friction blisters. Also watch for neuromas, and then athletes who are skeletally immature, if they have pain, look for bony overgrowth potentially. Again, there's not too much you can do unless, one, you may want to consider having them get out of their prosthesis and going on crutches if it's really painful. But usually if there's a bony overgrowth causing an issue, you could either get the prosthesis changed and refitted, or surgical intervention. But again, you're not going to be able to do this on the sideline. For overuse injuries, also remember that these can happen in the unaffected limb. So don't just focus on the limb that is amputated or not typically developed. And then because of altered skeletal loading, they may have different osseous deformities or fracture risk. When traveling, sometimes athletes may develop swelling in their residual limb. And so this can impact their prosthesis fit when they arrive. And so try to encourage them to wear a shrinker or their prosthesis in flight if possible. And then again, they may have, depending on the limb deficiency nature, if it's congenital, certain congenital conditions have an increased risk of patellar instability or ACL deficiency with their limb deficiency. So again, it's important to know the athlete's underlying medical conditions, check on their prosthesis fit ideally before they're traveling, well in advance, weeks before, so that if they do need adjustments, they can go see their prosthetist. Make sure that athletes have a good method for controlling hyperhidrosis, as this is a big issue. If you suspect an infection, you should treat it aggressively. I try to avoid breaking the skin if possible, and treat them with antimicrobials. Encourage athletes to wear their prosthesis or shrinker when traveling, and then watch for signs of fracture, not just pain, but swelling in insensate areas, because they may not present with pain if it's insensate. For athletes with cerebral palsy or brain injury or stroke, or what we call cerebral palsy mimickers, which also includes hereditary spastic paraparesis, hypertonia has to be from a central nervous system pathology per the Paralympic sport eligibility criteria. So that if you see an athlete with hypertonia, it's most likely from a central process. But there's a wide variety of clinical presentations and large spectrum of functional abilities. The underlying etiology is also variable, right? Just depending what you see with brain injury or even with cerebral palsy, right? Not everyone is born with cerebral palsy. If you've had a brain injury before the age of 2 years of age and it impacts your motor system, by definition, that's cerebral palsy, right? So you may have developed cerebral palsy from a brain injury at 1.5 years old from a motor vehicle accident, right? So there's a lot of different causes. Again, it's really important to know that athlete's underlying medical history. And there are many different types of muscle tone that you can see, including spasticity, dystonia, rigidity, athetosis, hypotonia, chorea, hemibolismus. So it just depends on what parts of the nervous system are impacted. Again, just like in spinal cord injury, if you see a sudden change in muscle tone, don't just treat the change in muscle tone. Look for an underlying etiology, because muscle tone should not just change randomly. Look for a noxious stimulus. If someone has a baclofen pump, or if they're on baclofen and all of a sudden you notice the mnemonic is itchy, witchy, or twitchy, be cautious of baclift and withdrawal. And again, some athletes in this category may have a shunt, like a VP shunt, or some type of brain shunt. So watch for signs of shunt malfunction. Some may have seizures, so have a plan in your emergency action plan on what you would do if you had an athlete who developed a seizure. Similar to spinal cord injury, decreased bone mineral density, particularly if they're on anti-epileptics, but also if they have impaired mobility or weight bearing, nutrition deficiencies. Watch for fractures that you wouldn't otherwise suspect, and remember that they may not present the typical way of a fracture. They may have just swelling or increased spasticity. And then, like we talked about previously, knowing what medications they're on will give you hints as to side effects to watch for, such as arrhythmia or heat exhaustion for neurostimulants that are commonly seen in this population. And then again, anticholinergics are seen in this population. So watch for heat illness. You can also make sure to watch for muscle imbalances, which can lead to overuse syndromes, muscle strains, patellofemoral pain syndrome. A lot of this population, particularly if they've had their medical condition since they were young, will have acetabular dysplasia or hip subluxation. So watch for hip injuries, scoliosis, which, again, you need to be thoughtful of, because depending on the severity there, that could also predispose them to tethered cord syndrome if they're still developing or growing. Many may have a limb length discrepancy, decreased cardiorespiratory endurance, which then impacts their energy reserve as well as their sport performance. Variability on cognitive involvement. Some are very bright and some have very lower functions with cognitive skills. And so again, knowing what their baseline looks like. And then there's many different disorders for communication, including speech, hearing, and vision. And then sleep impairment is another thing to consider, particularly when they're traveling. So again, know the athlete's medical history, know their baseline exam, including their baseline cognitive function and communication skills and their muscle tone, and have a lower threshold to work up for fracture and concern for shunt malfunction and seizures. You should go to the emergency department. So neuromuscular conditions. Traditionally, we used to not see a lot of these in these sporting environments, but as medical technology has improved with gene therapies or different types of medications that have halted the pathology process in these neuromuscular diseases, particularly in the dystrophinopathies or spinal muscular atrophy, I have seen more of these medical conditions pop up in the Paralympic movement. And so it's important to understand these medical conditions and risks to look for. And then this category also includes milder neuromuscular conditions such as Charcot-Marie-Tooth, which is a polyneuropathy. And so there's a wide spectrum of muscle endurance and fatigue issues in this population. You need to watch for the risk of rhabdomyolysis, as well as cardiac issues that may be associated with their underlying neuromuscular conditions, and pulmonary issues. The other things to consider here, sorry, this is a duplicate slide. I don't know what happened, but the other things to look at are contractures and sleep impairment. So for medical preparation, know what medications they're on, know what their exercise thresholds are. Make sure you meet with the athlete and their family beforehand, or coaches, and provide a lot of education. And make sure you know what their cardiac testing and pulmonary testing look like at baseline before they compete. Athletes with achondroplasia, also known as dwarfism. Things to look for here are spinal stenosis, particularly of the craniocervical compression from the foramen magnum stenosis, but they also are increased risk for tethered cord syndrome, hydrocephalus, and the spinal cord syrinx. Other medical conditions you can see are Chiari malformations, thoracolumbar kyphosis, and lumbar lordosis, contractures, central and obstructive sleep apnea, middle ear dysfunction, and hearing loss. So you should image athletes if you have any suspicion for brain or spine pathology. So if you're seeing any upper motor neuron signs, you should have a low threshold to screen them for that. And then also consider sleep studies or pulmonary testing if they have signs of pathology there, particularly if you're a team physician taking care of athletes while they're traveling. This can make a big impact. We also do see athletes with osteogenesis imperfecta or other types of bone metabolism issues in the Paralympic movement. And So it's important to look for fractures, mainly of the long bones, but also it can affect the axial skeleton in OI. But remember, they also have other pathology outside of bones, right? It's not just about the bones. So they can have retinal detachment or aortic dilatation, right? So it impacts multiple organ systems. Other things you can see is hearing loss, other eye diseases, abnormal dentition, reduced pulmonary capacity from just the anatomy changes that they have, weakness due to the impaired collagen synthesis, and then contractures. So make sure to avoid contact or collision activities, obviously. And then also consider cardiac and pulmonary testing in this population. For athletes with visual impairments, so just a reminder, legal blindness is 2200 or less in the better eye with correction or an angular visual field of no greater than 20 degrees. So medical emergencies or urgencies to consider here depend on the underlying etiology. So it's again important. There's lots of different reasons that someone may experience a visual impairment or blindness, right? So understanding their underlying etiology can give you hints as to what other things to keep an eye for when they present with symptoms to you. Because they have the visual impairment, they are at increased risk for acute injuries of distal extremities and also concussion. So it's very important to think about that when you are taking care of athletes, but also when you're trying to provide education for prevention and looking at techniques to prevent these injuries. Athletes with visual impairment also are at increased risk for overuse injuries due to altered biomechanics. Sometimes poor proprioception, although depending on if an athlete's been dealing with, been living with visual impairment since they were born or for a really long time in their life, their proprioceptive sense may actually be, and their balance may actually be a lot stronger compared to someone without any impairment. So it just depends, right? Because different sensory systems overdevelop to adapt and compensate for other sensory systems that are not working as well. And so, it just depends on the athlete. Always ask athletes what types of assistance they need. Don't just assume. And that's the case for all of our Paralympic athletes or athletes with disabilities. And then provide education about concussion, acute injuries, and when to seek medical counsel. For athletes with intellectual impairment, for the Paralympic movement, for eligibility, the intellectual impairment does need to be diagnosed before the age of 18. So, sometimes with someone who is an adult who develops a brain injury, you can see intellectual impairment from like cognitive impairment, right? But those are not eligible under this criteria for Paralympics. The underlying etiology is quite variable, right? You might have an athlete who has intellectual disability without any known etiology, or they might have autism or Down syndrome or many other genetic or neurologic conditions. So again, knowing the etiology and their other medical history is very important here to give you clues as to what other things to look for in terms of taking care of these athletes. For athletes with Down syndrome, watch out for atlantoaxial instability. Also look for seizures with some of these syndromes that cause intellectual impairment, cardiac events, because many conditions that lead to intellectual impairment also have a cardiac anomaly history. And then because this population may be more likely to be on antipsychotics or anti-epileptic medications, know the potential side effects of the medications they're on too, like such as long QT syndrome, thermoregulatory impairment, or decreased bone mineral density. So other considerations here, they may have some underlying eye or hearing issues, congenital cardiac anomalies, thyroid disease, GI atresias, impaired communication. So one, knowing what's their baseline for communication and what their preference is for communication, but also trying to figure out a good system with their family on looking for other ways they may not be feeling well or be dealing with an injury, because they may not readily report those symptoms to you or recognize that it signifies something for which they need medical attention. They also, in this population, you're more likely to see hypotonia. And then we talked about the medications previously. So again, it's really important to obtain the baseline medical history from a family member or guardian. And then also performing cardiac testing if they have a history that's relevant for that. Cervical spine radiograph screening, in the past, we used to recommend this for all athletes with Down syndrome. This is no longer routinely recommended unless you see signs or symptoms. So that's a big change. And then again, it's very important to develop a strong relationship with the athlete or their family members so that you know them. And then in the Paralympic movement, we also worry about safe sport. And so you always should have another adult with you to protect yourself. So again, this whole talk, concussion and parasport, can be its own talk, our talk. So we're not gonna be able to delve into this too much today, but I did want to let you know that this is a resource that's available. It is the first position statement for concussion and parasport. And what I love about this position statement is the appendix area has a bunch of these grids that you see on the right side, and they're specific to the more common medical conditions we see in the Paralympic movement. For instance, this one is an example for cerebral palsy athletes with spastic diplegia, and it uses the green, the traffic light system. So green means, these are red flags to look for, green for like different types of physical exam maneuvers you may want to do, versus yellow is, consider it maybe, but not in all athletes. And then red is most likely not going to work out for that athlete. So I like it really. I think it's a really great resource for someone who is not as familiar with working with athletes with different medical conditions or disabilities. So it's a nice little cheat sheet to be able to reference for when you're evaluating an athlete with a concussion. So take home points. There's been significant progress that has been demonstrated in the adaptive and parasports world, but so much more work and advocacy is needed. There are many different adaptive and parasport movements and organizations, and each have different criteria for participation and missions. Ideal preparation for sports medicine support of athletes with disabilities involves strong understanding of underlying medical conditions and associated risk factors or comorbidities, and strong traditional sports medicine preparation, including emergency action plans, well-stocked medical bag, pre-participation physicals, etc. So here are some resources if you are interested in learning more about different adaptive sports things. Here's some more clinical resources that you can look up. And I hope you enjoyed this talk today and are able to learn something from it. Thank you for having me. Have a good night.